now, when we talk about caries for the ADC exams, it is one of the most important topics. And why I say that is because the maximum number of patients that you see at your clinic, their first thing that you look out for is caries, right? So I would say that's our bread and butter as well. But not just that, we dig deeper into dental caries as a topic because it's a lot more varied and diverse than what we think it to be. It's not just dental caries etiology that we're dealing with. We're dealing with prevention, oral health promotion. We're dealing with fluorides. We're dealing with all the other agents that we are using. So let's break it down with the help of this particular presentation today. First thing is caries risk assessment. So if you have gone through the video library, there is one video lecture, which is dedicated completely on risk assessment for caries. We are not using the term moderate risk. We are either differentiating the categories as low or high. There's no middle one here. So let's revise it quickly. When you see the caregiver has active caries, like the mother, of course, or low socioeconomic background or status, or any child who's having a very heavy sugar containing meal, which is more than 3 times in between meals, right? Snacks which are in between meals, not with the meals, or if they are put to bed with a bottle containing natural or added sugar, with simple milk as well will have sugar in it, right? So all of this is basically high risk of caries. If none of this is present, only then you can put it as low risk. Like if you see here that they have regular dental care, they're using optimal fluoride products, and they have additional home measures, etc. This is all given in our video lecture for ICDS, and I've explained upon how to determine, detect, decide, and what do you do for preventing caries as well. Okay, so this is your caries protective factors. First thing you look out for is how is the patient brushing? Are they using a fluoridated paste? I would say go to therapeutic guidelines to reinforce this. What are the dosages or what are the ppms that we look out for when it comes to fluoride pastes? Because it's important that we know when to use 5000 ppm, when to use 500, when to use 1000. Okay. Regular dental care and systemic fluoride. The only way we need to have access to systemic fluoride is through drinking water. That is it. No other supplements, droplets, tablets, or anything of that sort is now recommended in Australia. Okay, earlier it was, now it's not. You have other risk factors. Now we're not just talking about children, we're talking about adults, sometimes the elderly population, or anyone who's on a lot of medications, antihypertensives, antidepressants, cholinergic medications. A lot of these medications can cause dry mouth. You put them directly under the risk factor, which is high risk. So you see how they've very correctly used the color red, which means danger or red flag. Any of these things which are a yes, your patient is in a high risk of caries. Okay. Additionally, for these reasons as well, anyone who's not brushing twice, mothers having active caries, all of these factors. So we've discussed this in detail. Now, when you look at caries, what do you look out for? ICDAS, this is the, caries, how would I say, terminology that we are following, and that's what TG has now updated as well. We used to follow I think the Evans article up till now. That is also still relevant. It pretty much talks about the same thing, but ICDS has given us visual stages and how to treat them as well. This is a zero category. There is no change of enamel translucency due to caries, even after you air dry the area. Okay. The next is 1 and 2. ICDS 1 and 2. What do you see? You see carious opacity, visible discoloration. It could be a white one like an incipient caries we saw at one of our in the earlier scenario, or a brown spot, which is not consistent with clinical appearance of sound enamel, but there is no breakdown that you see. There is no underlying dentine shadowing or cavitation. So this is, you see how you, when you differentiate this tooth from this, you can easily see how there is a, discoloration here, but it doesn't look like there is any dentine shadowing underneath. Now, ICDS 3 and 4 is moderate breakdown and moderate underlying dentinal shadow. Like, can you see a shadow here? There's no breakdown that you see, but you can clearly see a shadow. Here, you start seeing a moderate enamel breakdown. Microcavity, there could be a discontinuity. It is best seen after air drying. And on this, you see visibly discolored dentine through the intact or enamel surface. Um, and you can see this even on the tooth surface wet. Okay. They've given us a special note here. This is the highest category, which is difficult to, highest challenge category, because you need to not only diagnose, you need to manage these patients now. Okay, you need to take radiographs to see the extent of the caries and then decide what is the approach you're going to be taking. With this one, you're taking, now this of course is a very obvious cavitation. There is no doubt about it. You can easily probe around this area. You can extend your probe and see how deep it's going, etc. Okay. So, your caries classification should be easily based on this classification. Do they ask you questions about what is stage 4 or what is ICDS 1? No. They will just give you a scenario and you need to answer based on that. Okay, they will not ask you the classifications. Now, this is not a very clear radiograph, but I will make it clear for you. This is an incipient caries. You cannot really see it on a radiograph. Very mild enamel breakdown. The white, this thing that you see here, demarcation, this is clearly your enamel. See, enamel here, enamel here. The moment you go past enamel, you see dentine, and this is your pulp. Okay. So here you see very minute incipient caries. Moderate is when this starts going into the dentine, but it still hasn't approached dentine yet. I'm now showing you how to read radiographs. Advanced caries, again, don't worry about the terms used here. We should be more focused about what you see here. You can see clearly these things on a bite wing X-ray. This is your advanced caries now, which has gone into the outer thirds of dentine. This is still not inner third of dentine. This is for sure a very severe caries. It's almost approaching pulp, etc. Now, active in versus inactive, very, very clear, white to brown inactive, and you can see plaque coverage, matte frost, rough lesions. Dentine has soft wet, which is not discolored probably, and inactive is just the opposite. Okay, so there we've seen pictures for that as well. Inactive. If you want more practice today, have a look at least 50 pictures of how a rested caries looks like and what a normal active caries looks like. Okay, do that for a, homework, I would say, as a homework, and write it down for sure on a piece of paper. I should know how to spot these. Demineralization and white spots associated with early non-cavitated lesions can be seen also on smooth surfaces of the teeth along the gums or gingiva and interproximal areas. Based on the ICDAS system, if no lesion is apparent on a smooth surface when the tooth is wet, but a non-cavitated lesion appears when the tooth is dried, it is classified as code 1. Again, remember, you don't have to know the definition by heart. You just need to know, what do I do if it's a code 1? You don't drill, you remineralize. Now, when you're seeing a lesion which is discolored, or you see a non-cavitated lesion, it could be, dentine discoloration as well, but you're seeing it when the tooth is either wet or dry or both. That's when you do it as, classified as code 2, and so on and so forth. Always look out for plaque stagnation areas, dull appearance, presence of a rough appearance, or even surface breakdown, which indicates active lesions. Okay, inactive, again, we have discussed this in the previous slide. So this is my active lesion in the occlusal surface. I can call it as incipient, but I also see plaque, over here. This is my inactive lesion because it's a darker color. I don't see much plaque around it. Again, let me tell you, if in the exam you get a image like this, don't think you'll have a lot of confusion diagnosing whether this case is a high caries or low caries, because a lot of other information will be given to you to help you reach the correct answer. The lecture that I'm taking right now is for us to get our concepts right, our basics right. These are white spot lesions, which are commonly seen after orthodontic treatment. So we have had questions in the past where they've given us these kind of lesions and they've asked us to diagnose why, or what could have been the reason for this to happen. So can you see how this looks like a bracket? So the bracket would have been here, which means there was plaque stagnation around it. And again, I can see some square spots here. It's not a very clear picture, but there's plaque around the areas where the black bracket was initially. And then root caries. So there are various kinds of caries. Root caries occurs usually in middle-aged to older adults. There is yellow to brown discoloration. Traditionally, inactive lesions are darker in color, harder when probed, but active lesions are soft, leathery, and lighter in color. So if you remember our first scenario-based question that we had discussed, I showed you a picture and one of the options was active root lesions. It wasn't active because the color was very dark. In many patients, the activity of any given lesion can be assessed by observation over a period of time. As such, the length of the time between recall appointments needs to be carefully considered. I would say recall appointment is so important because if you do not recall at the right time, you are losing track of how the caries is progressing. So for us, TG has outlined and the various ADA guidelines have outlined that we need to call the patient at every 3 months to check for high caries, any patient who has a high caries risk. Root carious lesions, again coming back to this, they begin usually on the buccal and lingual root surfaces, easy to identify. The same cannot be said of interproximal lesions and subgingival lesions. A good radiograph is a prerequisite for the diagnosis of early root caries lesions. Older adults should regularly undergo screening for root caries because most of the times they're asymptomatic. So even if they progress, probably because of pulp calcifications and other factors, dentinal, sclerosis, elderly population doesn't have any symptoms. So you can see how this is a root caries. This is going deeper. How will I differentiate? Can anyone tell me how will you differentiate this kind of caries between, root caries and cervical burnout on this radiograph? Why would you call it as a root caries and not cervical burnout? I hope everyone knows what's a cervical burnout. Okay. So to answer this, cervical burnout usually occurs, if it occurs, you can see it on both the sides. It's not just, seen on one side only. If you have to differentiate between caries and cervical burnouts will usually start they'll start below the CEJ. If this is my CEJ, it'll start here. It's usually because of the angulation or sometimes the density of the, X-ray as well. But you will not see it only unilaterally. Okay. Yes, again, like you said, Pavi, there is breakdown in the CEJ, but it's also unilateral. So that will help me more in diagnosing it as root caries and not just cervical burnout. Cervical burnouts, you won't see any breakdown, clear breakdown. And if you try and change the angle, again, you're right, it will help you diagnose it better. All right, so yeah, good pointers there. For root caries, like I said, you'll have probably see it in older generation, like the older population, males, low socioeconomic status, and the rest of them are pretty much same for a high caries risk, right? Anyone with a normal high caries risk category factors, they're the same. Prevention and treatment. This is all of your health promotion. You know how ADC has a cluster of health promotion? This is what constitutes 10 to 20% of it. Actually, more than that. What are you doing to educate your patient on how to maintain a good oral hygiene? Maintenance and improvement of oral hygiene is the first step towards prevention of root caries. So dietary sugars is the main factor, control it. Educate your patient, make them aware on what to eat, how to eat and stuff. Routine use of fluoride pastes and drinking fluoridated tap water is also important, especially for people who have got dry mouth. Sometimes you'll see options where they'll ask you, what will you give them for dry mouth? And the options are salivary substitutes, changing their medication. The most easiest way is ask them to drink or sip water regularly. And this is also usually given in the options, but candidates often start thinking of complex answers. No, ADC wants you to choose, or generally, you should be choosing the most common thing that you can advise your patient. It is the most economical thing to do. Have water. It's not expensive, it's cheap, it's readily available. It's the one stop solution for preventing caries. Drinking fluoridated water. In Australia, most of the areas are, they have a supply of fluoridated water, except for rural areas or some regional areas where you have tank water or rainwater. All right. So specific measures, even using electric brushes, chemical plaque control like chlorhexidine, etc., could be advised to the patients. And you've got to also keep in mind that these patients have gingival recession and perio disease. So correct techniques of brushing, oral hygiene instructions are very important. If you have someone who cannot carry out their activities of brushing every day carefully, or have dementia and other conditions, you need to be more careful and just maybe advise their carers of the same. Okay, so education of the carers is as important in a population of people who have these cognitive impairments. Treatment strategies are, it depends upon the size, type, extent of aesthetic requirements as well. Early lesions which are accessible, and remember, this is only for root caries, okay? Early lesions which are accessible and cleansable should be treated conservatively with fluoride varnish. Professionally applied high fluoride varnish or gel or professionally recommended use of high fluoride toothpaste has been successful in controlling root decay. So do not go and start filling up these areas immediately. Rather than that, focus more on prevention. Apply varnish every now and then. Advise them on using a high fluoridated paste just to prevent any more caries. Advanced lesions can benefit from remineralizing effect of fluoride treatment and require less removal of tooth structure during restoration, or even may avoid restoration altogether. GICs or composites have been commonly used. However, the majority of restorations have failed due to poor visibility, access to the cavity, inadequate moisture control. You know how this gingival fluid always, if many of you have, done class 5, restorations, they're not always very successful. And these are factors which are responsible usually. So let's go back to using the traditional methods, conservative methods first. It's recommended that active root surface caries, which cannot be cleaned properly by the patients, you can always apply a GIC over there using minimally invasive approaches. Don't drill, don't roughen the surface, just use ART, which is, removing the caries with your hand instruments and applying a material like glass ionomer 1. This is a very complex chart. I don't want to, get you all to get confused. Rather than this, I think it's better if we follow TG, which is given us very clear-cut guidelines, okay, on what to do and how to educate our patients. I'll come to that as well. Okay. When you talk about determining the pulp status for caries, every time a patient comes to you with sensitivity or any such issues, always do a few tests. Now, tests are a part of our information gathering cluster, okay, investigations. So you always have to remember that there are no objective or definitive tests to determine the health of the pulpodentinal complex in a primary or an immature permanent tooth. You always correlate all the factors together. You do a pulp sensibility test, but not in the primary dentition. Okay, you might have heard this from me earlier as well. Children do not have the cognitive development to respond to this stimulus. So do not do these tests on them. In the immature permanent tooth, again, it's very difficult to get a direct response. So we can do it as a baseline. sometimes in cases of trauma, but not always to determine whether the pulp is, I mean, the nerves are dead or alive, whether the tooth is necrosed or not. In a When you have pain, especially young patients, they have very difficulty, they have a lot of difficulty in communicating their experience. It's often seen that patients, especially young children, they will only come to you, and you would have seen they'll come to you when they have an abscess. And if you ask their parents, do you notice there's a pimple around that area or a sinus? And they say that, yeah, it's only now we noticed it because he hasn't complained of anything. That's because the pain would have lasted for a, very short while. And in children, these effects happen very quickly. So the sequela that we see from caries involving the pulp, involving the roots, and then infection, all of that will happen much more quickly in children compared to adults. Which is why they often come to us only when they've reached that stage where the tooth either has to be pulled out or needs a nerve treatment. So always remember there are a lot of tests. For this particular slide, I would just like to keep our focus on one thing. Any primary tooth which shows you furcation involvement, furcation radiolucency, don't even think about saving that tooth. Radiographic examination should be considered essential before taking endodontic procedures. The presence of caries in furcation or internal or external root resorption or periapical and furcation bone lesions, they're all contraindications for endodontic treatment in the primary dentition. This is my main takeaway from this slide. Okay, you'll often get these questions where they show you x-rays, primary teeth with furcation radiolucencies, or even physiological root resorption is happening. Don't do root canals in them. Don't attempt it. Okay. Um, Minimum intervention dentistry, so important. You'll actually see a lot of courses now marketing themselves in dentistry to be minimally invasive and biomimetic and all of that, right? So the concept of MID for managing carious lesions has been developed based on biological concepts and evidence-based outcomes of novel and existing caries control interventions. It's all the same, guys. It's all what TG tells us to do. It's the same thing, but we need to know clearly what it is. So let me take you directly to such, minimally invasive interventions. Specifically for primary teeth, minimal intervention caries control strategies include a wide range of approaches, including where carious tissue removal is not involved. So it's a big no-no. You are not removing any caries. So what are you doing for that? Sealing the carious lesion with fissure sealants, resin infiltration, silver diamine fluoride. I don't know how many of you have used it or heard of it. This is an excellent option for young kids who are non-compliant, who come from really far away and they cannot come back and forth for various appointments, etc. And I've tried this personally. It works wonderfully well. But you just need to be a bit more cautious when you use this material or product. And the Hall technique. The fact that you're listening about all of these names, make a note of them, take out time during the week and read these from the ADA guidelines folder that you have, okay? You must know what are the indications and contraindications for Hall technique, when are we using silver diamine, etc., etc. When managing primary teeth with caries, surgical method is less preferred because it removes extensive tooth structure where the tooth morphology already presents of challenges of thin enamel and dentine and large pulp chambers. Okay, so often you also need to use LA, and not all the children are very comfortable with LA in, in for caries removal, etc. So always think of using your minimal intervention techniques, and they have been summarized very beautifully in these four ways: silver diamine, Hall technique, fissure sealants, resin infiltration. Okay. I've taken the risk assessment lecture from cariesinternational.com, and if you've gone through that lecture, I think you don't even need to go through this. I'll share this wonderful link for diagnosing caries on X-rays, and I'll share it right away with all of you. Go through it today itself. Okay, just give me a second, please. All right. Now our focus is on what TG is telling us from from the latest updates that they've given us on the topic of dental caries. So you remember how I shared the video lecture on acute odontogenic infections and what are the changes they have made. These are the changes for dental caries, and I will add this as a separate, video lecture in our video library as well for dental under the topic of dental caries. But this is what TG has told us. Okay. So, in the previous TG discussions, if you want, you can forego that and you can now follow this. It's the same thing. It's not much of a difference, but because it's updated, it's important for us to know. So, we know dental caries is a pathological process resulting in localized destruction of tooth tissue, very easy to follow. Plaque is a complex biofilm of mixed bacteria and byproducts, and plaque is always a prerequisite for dental caries development. What are the etiological factors? Frequent exposure to dietary sugar, carbs, and anything which is acidic in the diet. Everything is related to dental caries, right? Early carious lesions will begin as white spots on the tooth that have a relatively intact surface. Early diagnosis is very important to arrest the lesion and reverse it. So these are early carious lesions and these are cavities. Why are we calling them as cavities? And I know this is too basic, but sometimes it's important for us to stay rooted, deep rooted with our basics for ADC exams. Because there's evidence of cavitation here, breakdown, that's why it's called as cavities. These are just lesions, white spot lesions. Okay, they are not cavities. How do you diagnose it? Of course, radiographs and visual techniques. You use magnification, dry the teeth, or even sometimes light-induced fluorescence. Not every clinic will be following the most advanced techniques, but the basic ones are these. Never ever probe your incipient lesions. Sharp probing of carious lesions will not improve detection, they cause further damage to the tooth. So do not probe it. If you get any option where they have for code 1 lesions probing, don't opt for it. You know the sequela. If you leave them untreated, you get pulpitis, necrosis, infection, apical periodontitis, leading eventually to spreading odontogenic infections. This is what TG has adapted, sorry, from the ICDAS, and I just showed you the slides as well. This is the same thing. This is ICDAS 0. There is no change or breakdown of enamel, no change in the color. This is code 1 and 2. White or brown discoloration without any breakdown, just a shadowing. There's not much, that you can see, but this is clearly visible as a cavitation. And of course, there's extensive plaque overlying it. So this is our high risk, very high risk. I would consider this as high risk as well if I have other factors present. If my patient's brushing twice, no such issues of diet as well, flossing once daily and has 1 or 2 teeth with such lesions, I'm going to categorize them as low caries risk, okay? Again, TG has adapted the caries risk assessment from the same resource of International Caries, system, which we have spoken about in the video library. So I'm not spending a lot of time on this part. Management is what I want to spend more time on. So, minimal intervention for dental caries. Start off with minimal intervention, dietary modification, avoiding sucrose in sticky forms. Many times you have parents in OSCEs also, they give you scenarios or in part 1, and the parent says, my child is not eating anything, sweet. He just has like homemade cookies and pancakes with homemade maple syrup and blah, blah, blah. No, all of that is not good. He's having sultanas, raisins. And he's got, he just likes those. They're just dry fruits. No, they're sticky in nature. They've got high content of sugar in it. So that is also something that needs to be managed. Plaque retention reduction, brushing twice with a fluoridated paste. Sometimes you have certain challenges where people don't believe in fluoride. They say fluoride is poison, it's toxic, it's not good for us, it's not good for the environment. Well, that's your belief, but our ADA guidelines clearly suggest that if it's taken in a limited amount, It's really good for our teeth, for preventing caries and remineralizing as well. All you can do is educate the patient. You can't force them to change their ideology. Interdental cleaning, flossing once a day, surface modification, using remineralizing agents, fissure sealants, and fillings, of course, if are needed. Saliva modification, address the causes of dry mouth. Dry mouth is a very important aspect we are going to cover in oral mucosal lesions. Using low acid, sugar free chewing gum, very important. Non acidic food, carrots, which is going to increase the salivary flow. All of this is your minimal intervention strategies. If cavitation has occurred, like if you see something like this, in addition to the prevention strategies, you do a filling. Okay, restore it with your preferred choice of material. If I have to restore this, and if the patient doesn't have high aesthetic needs, I would go with the GIC because I cannot control the fluid around here, right? And composite has to be done under very good isolation. Okay, so that's something that to think about. Yeah. Fluorides. What are we using as fluorides? We are using it in the form of toothpastes. That is the first thing that we are using. The other products are mouthwashes, gels, varnishes, etc. So you can use this in addition to toothpaste for somebody at a high risk of caries. Water fluoridation is very important, like I've already talked about it. Inexpensive, effective. No supplements should be given in the form of drops or tablets. Not recommended at all. Now, sometimes coming to this paragraph, if you read this, fluoride promotes enamel remineralization through fluorapatite and fluorhydroxyapatite. They give you options like these in the exam as well. So remember these terms, please. Okay. They are more resistant to future acid challenge. Most of the common toothpastes contain sodium fluoride, but if they ask you in the questions which element is responsible for desensitization, or if a patient has sensitivity, which is the element in the toothpaste which is important to combat that, then it's stannous fluoride, not sodium fluoride. Stannous fluoride toothpaste formulations have the advantage of antimicrobial effects and they reduce dentinal hypersensitivity. Okay. Non-fluoridated pastes are a subject of research not recommended as the sole first line prevention. Okay, so non-fluoridated pastes are for people who think fluorides are toxic. They can use it, herbal pastes, etc., but they're not as useful. Toothpastes that do not contain fluoride provide little protection against dental caries, and children up to 6 years of age who ingest a lot of fluoride during the tooth forming years are at a risk of fluorosis. All of this, you must read from the ADA guidelines. Write down these topics: fluorosis, what is the etiology behind it, how to manage it. Um, and of course, dental caries management, as we are discussing now. To reduce the ingestion of fluoride after brushing, pastes should be spat out rather than swallowed. Young children get fluorosis, you know why? Not because of their habit of, because they grew up in a high fluoride area while their teeth were growing as well. Mostly is because they ingest or they swallow a lot of toothpaste, especially when they're at the age of 4, 5, 6, and that's when, or 3, 4, 5, that's when the teeth are also calcifying at the same time. So it's important that they don't. That's why supervision is so important for children up till the age of 8. So the fluoride ingestion can be reduced by parental supervision and by using a product with an appropriate fluoride concentration. So in a summary, remember, it's a lot of things we are looking at. If my patient is a 4-year-old, as we saw in the scenario, and he's a high risk of caries, person, I have to advise him a high fluoride paste. I can advise, according to TG, I can advise 1,000 ppm of fluoride twice daily. But my terms and conditions are it has to be strictly supervised. Otherwise, the child might just end up, if they like the taste or something, they'll just swallow it. And that puts them at a risk of fluorosis. So look out for all these factors. This is what is given in TG very clearly. You can take pictures. I can share it in our group as well. This is for somebody who's not at a risk of caries. I'm not going and reading out each one in detail. You have to learn it. I would suggest taking printouts as well. And this is for high risk of caries. And coming to, I think, Sanyukta's question of, when to use combination of products, this is what it is. Examples of topical fluoride to use at home. This is something that you can use at home. You can use a mouthwash, but only if the child is more than 6 years of age. Okay, rinse for 1 minute any time of the day, or when the toothpaste is not used. Okay, and this is the concentration. These are two concentrations that they've given. So you had asked me about fluoride plus CPP ACP. Yes, that can be given, but use in adults and children for non-cavitated initial lesions twice after brushing with usual fluoride paste. So these are all adjuncts that we are using, okay? Avoid using CPP ACP in patients who are allergic to dairy because it has a milk protein called as casein. How do you apply CPP ACP? You apply it on the teeth and you leave it on for 3 to 5 minutes, spit it out, and do not rinse. So basically, you should do it right before sleeping so it stays in the mouth for a good amount of time and the contact period increases. Okay. And they've given you multiple other things, but the difference is this is something you can use at home. These are at a clinic, only to be applied by a dental practitioner. A varnish, APF gel, neutral fluoride gel, silver diamine, they are not to be used for home. Okay, very clear distinction out here. Fluoride varnishes, of course, the ages are, there's no age limit as such. For somebody who's at a high risk, I will mention you can use it 3 to 4 times a year. Okay, they have to be applied by a dental practitioner. APF is another, kind of topical fluoride which can be used, but it is only used in children more than the age of 10. Okay, and gels are more effective in permanent dentition than in primary teeth. Okay, so we have gel which is applied like APF gel, which is applied by dental practitioners using trays. The only thing is avoid these gels in patients who have ceramic work, bridge work, crowns, restorations, which is why we don't use a lot of this because almost everyone these days will have fillings, at least composite fillings or old fillings, and more, such conditions like these. So varnishes are used more. You can use neutral fluoride gels again more than 10 years of age. So please remember these things. They are really important. Silver diamine, I will show you in a minute what are their clear indications and everything. They also have to be applied only to stabilize caries. They should be used on tooth surfaces where there is no cosmetic concern. The biggest disadvantage of SDF is it will stain your teeth black. None of the other products do that. So SDF will stain your teeth black. It is excellent, but it's used basically for back teeth or for primary teeth where aesthetics is not a concern. All right. And this is your fluoride plus CPP ACP, which can be used again in adults and children. There's no age limit that they've given here. So you can do that. If this was an option, you could have chosen this as well. Okay. Non-fluoride is basically our, CPP, ACP in combination with fluoride, the same combination that they're showing us here. This is all given in updated TG, September 2025 updates given by Therapeutic Guidelines. So, just remember all of this. This is really important. Fluoride will always remain the first line therapy for primary prevention and treatment of dental caries. CPP ACP products should not replace fluoride intervention. However, they are just an additional treatment. Avoid them if your patient has a milk protein allergy or is allergic to dairy in general. Okay. If patient is unwilling to use fluoride, like I discussed, somebody who believes it's toxic, then you can give toothpaste. This is a new addition. This is very interesting. They hadn't mentioned this in the previous TG. Toothpastes using hydroxyapatite can be considered. I actually looked up, what are the toothpastes containing hydroxyapatite, and there were a few in the market that have come up. So you can just Google some names. However, they will not give you the trade names. Okay. We have a question saying the child is not being supervised in our scenario. Can we still take an option like Yes, that's what I meant. If your scenario says that it's not supervised, and first of all, educating the child is really important. I mean, not the child, sorry, the mother. We cannot be assuming that he will not be supervised in the future. But what we need to give them is the ideal. Remember, choose the ideal answers in the exam. So even if they don't mention something like whether the mom is going to supervise him or not, we need to give him something which is less fluoride but more frequent. Okay, not high fluoride and more frequent. CPP ACP, if you take it's they haven't mentioned anything like ingesting it will cause fluorosis, because it doesn't have fluoride at all. It has this CPP ACP, yeah, calcium and phosphate in an amorphous form, which doesn't have any major side effects if ingested. They haven't mentioned anything like that, so I believe you can say that anything unsupervised is definitely not correct. Okay, but CVP ACP in itself doesn't cause fluorosis. Tooth mousse plus, let me tell you, because you've asked this question, CPP ACP is tooth mousse. Tooth mousse plus is CPP ACP plus fluoride. Okay, so that's a difference that you need to look out for as well. But however, they'll give you the name, they'll not give you the trade name in the questions. Okay, so hydroxyapatite containing toothpastes, um, they are more efficient than non-fluoridated pastes. If your patient says, I don't believe in fluorides, give them a paste containing hydroxyapatite and tell them this is not fluoride, but this element or chemical is what is going to help in preventing decay in your teeth. So these are the various ways fluorides is delivered. You have topical, which are professionally given and self-applied. So at home, they're using mouthwashes, gels, and pastes. And in professional environment at the clinic, we are using sodium fluoride, APF. We are using stannous fluoride. We are using varnish. Most commonly, it's the varnish. These are a few pictures I wanted to show everyone. Just this is your CPP ACP with fluoride, and plain tooth mousse without a plus is just CPP ACP. This is a 5,000 plus ppm fluoride for adults with high caries risk. This is how you apply a varnish basically on teeth, even on root caries which are inactive. You can apply these. Durafat is again sodium fluoride, in a dental gel form. You can apply some foam through trays, but foam is now not recommended anymore. I will show you you know, the slide for this, where ADA has come up with a recent guidelines, even TG, that foams are no longer to be used because of I think the efficacy is not that as much. Yeah, this was about dental caries. Just a minute, please. I'll just answer your question in a while, Monica. I just wanted to show everyone, because this is being used so commonly for kid patients, especially in public sector. I want to talk about silver diamine fluoride. So this is what's silver diamine fluoride. I told you that it can stain your teeth black, but in the primary dentition, it's fine. Imagine a non-compliant kid, okay, who doesn't have he's not even he's very scared of dent or has dental phobia, or is a naughty child maybe, not ready to sit. All you want to do is not, I mean, for this lesion not to progress. If you pick up your drill, he's going to run out and never come back. You just apply SDF. Okay, and this is how it's going to be, but at least the lesion is going to be arrested. So it's groundbreaking actually. Only thing is, be very careful of your case selection. Does the child have an active carious lesion? If there is pulp involvement, straight away go for extraction or whatever treatment you're doing. Not into the pulp, what do you check for? Do you need to restore it? If the child allows you to restore, and if he doesn't have any behavioral needs, you restore it. But if they have some behavioral needs, sometimes children are on the spectrum, autistic and special needs, etc. If none of that is present, you restore. But if they have that, then you can go ahead with SDF or restoration. So they are applying SDF in all of these situations as well. Okay. In Australia, silver diamine fluoride is registered to treat even dentine hypersensitivity rather to prevent dental caries. As such, use of HDF to prevent dental caries is considered off-label, but we are still doing it. Off-label means something which is not TGA approved. Therapeutic guidelines, I think Therapeutic Goods Administration is the authority which approves all the products. So you are using it, they have said that it's for dentinal hypersensitivity, but it's an excellent method to even prevent caries. I know this statement doesn't say that, but TG says it. Remember in our chart, they say that SDF can be used additionally with fluoride use as well. So it is effective in arresting active carious lesions in the primary dentition and root caries in older adults. The major side effect is black staining of carious lesions caused by precipitation of metallic silver and silver oxide. While this is an indication of caries arrest, it is an important consideration is if aesthetic appearance is a concern. Okay, so always take an informed consent. It is also recommended in children with high caries risk, with behavioral complications, those who need multiple visits or without access to dental care. Okay. Again, the main disadvantage is the non-aesthetic black discoloration of the carious lesion, but there are various other methods by which it can be reduced. All right. So these are a few clinical features on when you use it and the follow-up after months or a few weeks. So you absolutely have to do no drilling, no nothing at all. Okay. And you just apply them and the lesions may get darker, but at least the caries is getting reduced or stopped, arrested over there. The use of SDF has important implications in pediatric dentistry and use of minimally invasive preventive care in community dental agencies. So they've just outlined how to use it. You can see they've used a floss as well. You can use it in small interproximal lesions, um, extensive interproximal lesions as well. So yes, it may turn black, but it's reversible. It may get better with time. Okay. Case selection. Who are the patients which benefit from SDF? High caries risk who have active cavitated caries in anterior and posterior teeth. Those who have behavioral and medical management challenges. Those with multiple cavitated lesions that may not be treated in one visit. And those with dental caries lesions which are difficult to treat or without access to dental care, in rural areas, etc. And the tooth should have no sign of pulp inflammation. Even if it's a slight sign, don't do SDF because it can worsen the condition. There are lesions which should not be encroaching the pulp. Radiographs have to be taken before you apply these. Cavitated caries lesions on any surface as long as they are accessible with a brush before for applying SDF. Okay. SDF can be used prior to restoration placement as a part of caries control therapy. Always take informed consent because when there is staining, it can be a bit dicey in those situations. Potential staining of even clothes and skin can happen sometimes around the lips if it's not applied correctly. So that's about SDF. They have talked a lot about it, and even the updates in TG talks about it. So it's important that we have information about this. So that was about dental caries. I'll just stop the recording.